Myself, Dr. Santosh Routray, a medicine specialist, District Headquarter Hospital, Puri. My topic is a poorly controlled diabetes with hypoglycemic risk. 50 years old, type 2 diabetes for 2 years. Patient came with frequent hypoglycemia events in the past 2 months. He was taking metformin 1000 mg BID, sulfonylurea, that is glimepiride 2 mg twice a day. Laboratory investigation reflects glycosylated hemoglobin 8.2%, LDL 90 mg per deciliter, HDL 36 mg per deciliter, triglyceride 126 mg per deciliter, AST 33 units per liter, serum creatinine was 1.2 mg per deciliter, and estimated GFR 65 ml per minute for 1.73 meters square. A physical examination reflects BMI 31 kg per meter square. Blood pressure was 120 by 70 milligram per millimeter mercury. Heart rate 78 per minute. Optimized glycemic control with cardio-renal protection are the primary treatment consideration. And glycosylated hemoglobin goal for many non-pregnant adults of less than 7% is appropriate. On the basis of provider judgment and patient preference, achievement of lower glycosylated hemoglobin, such as less than 6.5%, may be acceptable if this can be achieved safely without significant hypoglycemia or other adverse effects of treatment. In the 21st century, type 2 diabetes has reached epidemic proportions globally. Indians have a tendency for earlier onset of type 2 diabetes, leading to an accelerated risk of developing complications, making it more essential to address this pathology early in disease course with available novel therapies having minimum risk of adverse events. Strict glycemic control is critically important in people with type 2 diabetes. Sulfonylureas like glycoside, glimepiride, glibenclamide, and etc. play a pivotal role in glycemic control. As a direct extension of their mechanism of action, the risk of hypoglycemia is increased, and this risk may be further increased in patients with renal impairment, which is a common comorbidity associated with type 2 diabetes. Hypoglycemia is a major concern for users of sulfonylureas. Magnitude and severity of sulfonylureas induced hypoglycemia range widely across. There is a strong rationale for combining a DPP-4 inhibitor and cardiovascular protective class of SGLT2 inhibitor in patients with type 2 diabetes because two drugs exert different and complementary glucose-lowering effects. Furthermore, the increase of glucagon levels induced by SGLT2 inhibitor may be blunted by the co-administration of DPP-4 inhibitor. Clinical evidence shows that SGLT2 inhibitor and DPP-4 inhibitor combination is an effective option for management of type 2 diabetes mellitus, providing glycosylated hemoglobin reductions of 1.1 to 1.5% and weight reduction of approximately 2 kg when added to metformin, which is its primary place in therapy. The American Diabetic Association recommends initial therapy should be considered in patients presenting with glycosylated levels 1.5 to 2% above target, considering absolute effectiveness of most oral medications rarely exceeds 1%. This unique combination lends itself readily to early treatment intensification because of good tolerability, low risk of hypoglycemia, possible weight loss, and minimal treatment burden. Clinical experience with the DPP-4 inhibitor and SGLT2 inhibitor combination shows that they can be used with a good safety profile and a low risk of adverse events, hypoglycemia and weight gain, even when added to metformin, which is a particularly important finding for clinicians. A reduction in the incidence of genital infections associated with the SGLT2 inhibitor has been reported when a DPP-4 inhibitor is added, perhaps because of a better glucose control, although other possible mechanisms remain to be investigated.